Hello and good evening, everyone. A warm welcome to everyone on today's session. I am Dr. Rashmi Shankar, Associate Consultant at Apollo Spectra Hospitals and your patron for today. It's an honor to be a part of the amazing platform of SPOC, that is the Society for Prevention of Cancer, its first monthly clinical meeting. I'd like to introduce to you all our very own, most successful and tenacious founder, director, and chairman of SPOC, Dr. Nanda Rajneesh. She is a GI, laparoscopic, breast surgeon and bariatric surgeon and surgical oncologist working at various hospitals, including Apollo Spectra Hospitals and Sakra World Hospitals, Bangalore. She is the founder member of the team at NOVA that pioneered the concept of short stay surgeries. As a leader, she's extensively involved in treating breast cancer and bringing awareness on breast career prevention. She has given many corporate talks, and she has also published many papers and the author of many books, few of them which include Life with Fibromyalgia and the Risk Factors in Breast Cancer. Ma'am, I hand over the session to you.
Thank you, Rashmi. So we are honored to be starting the first monthly meeting of Society for Prevention of Cancer. So Society for Prevention of Cancer is basically a non-profit organization. The intention of starting this organization was to take care of the healthy, also take care of the healthy to prevent cancer, that is one, and also in preventing recurrence of cancers. Because we have learned there are many reasons for cancers. When individual gets cancer, it is multifactorial. We know that. But when there are multifactorial reasons, it's very difficult to target one particular thing. So we want to come to some kind of consensus where we can work in a bigger way on preventing cancer. So that was the intention to start this foundation. And secondly, we also wanted to educate all the doctors. So the focus on prevention has come down in a bigger way because there is need for caregiving. So mostly the prevention is taken care by the public health department, but they don't have much time to take care of this for many reasons. So we started this to educate doctors, to educate health professionals, to educate cancer patients and the common population to work towards prevention of cancer. So there are some of us are founder directors, pioneer politicians, pioneer medical oncologists and surgeons in this group. And there are a lot of contributors and executive advisors in my committee, which have helped me in a big way to come up with a lot of projects and a lot of work that we are doing back to back. We conducted one major conference in 2021, 13th, 14th in Taj West End, and where many people attended this conference. We're starting the cancer prediction app. One book launch already happened and one more book launch is coming very soon. So we have many upcoming events where we have yoga classes happening for all our patients at no cost, everyday classes. And we have different batches also we are doing. And then we have many upcoming mass events that we are planning. And we are also working on different projects. One of our, in fact, founder directors herself is doing PhD in yoga and cancer prevention itself, this work going on. And we found out that immunity plays a big role. Yoga, exercise, meditation play a very big role in preventing cancer. Nutrition has a huge contribution because food is full of toxins and chemicals. We are planning many research projects in different fields. And this is just the beginning, what we are doing. And so we do know that, one guy, Yoshinori, got a Nobel Prize just for saying that, or to finding out that how intermittent fasting can boost immunity and prevent cancers. And simple things like sleeping well and being happy can prevent cancers. You should know this because stress has a huge association with cancer. So we are also targeting many individual cancer. And in the first lecture, we are starting with Dr. Sampath Chandra. I'll ask Rashmi to take over the session to introduce Dr. Sampath Chandra to take forward the lecture. Thank you.
Thank you, ma'am, for that introduction. Now, with immense joy, I would like to welcome our speaker, Dr. Sampath Chandra Prasad Rao, who is a consultant otolaryngologist, head and neck surgeon, skull-based surgeon. With his academic distinctions, prizes and honors, and achievements hitting the skyline, he has numerous publications and an author for various books. He has consulted in various hospitals, a few of which are Manipal, Columbia Asia, and Apollo Spectra hospitals. Sir, I would kindly ask you to take over the session.
Namaste. Thank you, Nanda Madam, and thank you, Dr. Rashmi, for hosting me, for providing this platform and extending your kindest invitation. It's a privilege for me to be a part of SPOC in various capacities. Nanda Madam has been very kind to include me in one of her prime ventures, which is to set up this flagship organization called Society of Prevention of Cancer, which I think is a very, very, I would say, a human service or the need of the hour. And no better person than Dr. Nanda Rajneesh to lead this organization and to set it up and take forward the activities. So once again, I thank you for the invitation and for letting me be the speaker for this series of online webinars. And my mandate today will be to speak on the pre-malignant conditions of the oral cavity. And let me begin by sharing the slide. I will ask you if you will be able to see my presentation. And yes, are we? Yes, okay. So I work at Manipal Hospital and at Apollo Spectra primarily, and I have my own sort of enterprise called Bangalore Skull Base Institute. I was trained in Europe for close to 7 years in skull base surgeries and in cochlear implantology. So we have the entire range of head and neck cancer and skull base and hearing implant portfolios, and we are based out of Koramangala, and we are a group of 4 consultants and 14 other non-teaching staff. So as many would know here, because I assume that we are speaking to a lot of doctors today, apart from the general public. For those who are familiar with this topic, we all know that oral pre-malignant lesions are form a considerable percent of the world's population, which is approximately 4.5%. Now, in India, it's been often seen that greater than 50% of the prevalence is in the population groups of like fishermen, in urban population who are tobacco consumers, in slum dwellers because of low immunity. And, it's in these specific populations that one gets to see pre-malignant conditions of the head and neck. Now, pre-malignant conditions turn into malignancies in roughly about 7.62% of the cases. And this is a study that was done in males predominantly, but I assume that the figures would not be much different in females of in the same populations that are susceptible to this disease. Now, this slide essentially here shows the conversion of what is a normal epithelium on the left-hand side of your screen to what is called carcinoma in situ or a pre-malignant condition. So a normal epithelium first turns into basal cell hyperplasia and then into squamous metaplasia. It could be a little too technical for the non-doctors who are in the audience, but let me try to simplify this and try to make it as easy as possible. So a normal epithelium, before it can get transformed into a cancer, into a carcinoma, a frank carcinoma, turns first into what is called a basal cell hyperplasia, which is in the epithelium, that is the uppermost lining of the skin or the structure, that the mucosa, and then it turns into what is called squamous metaplasia. So the squamous cells become metaplastic, which leads to frank dysplasia, which is a gross disorganization of cells in that area, which then leads into what is called carcinoma in situ, which is a precursor of frank squamous cell malignancy. And we keep talking about squamous cell malignancy because squamous cell carcinomas are the most common carcinomas in the head and neck area. There could be other carcinomas like adenocarcinoma, adenoid cystic carcinoma, but we are not here to get into every bit of the story. for the paucity of time. So in squamous cell carcinomas, which are the most common condition in the oral and in the laryngopharyngeal areas, what happens when the normal epithelium turns dysplastic or it goes into carcinoma in situ? So when that happens, you see that there is a constant inflammation. The bottom line here, you see there's a bar that shows inflammation. So this is an inflammatory process right in the beginning. Inflammation can be due to variety. It could be, inflammation due to external environment, due to contact ulcers, due to a sharp teeth or whatever. But there's always an underlying focus of inflammation, which which kind of forms the bedrock or foundation for these changes to occur. So then again, what happens at a microscopic level is that there is a proliferation or an increased activity of CD3 T lymphocytes, in the first half of the spectrum. Later on in the squamous metaplastic and dysplastic change times or durations, there's a increased activity of CD4, CD8 and T lymphocytes, and then come the TH1 cells and T regulatory cells, which all try to control the dysplasia or the metastatic changes, and they are aided by macrophages, neutrophils, and dendritic cells. So they all try to prevent the conversion of normal epithelium into squamous cell carcinoma. But then when the situation is towards the other end of the spectrum, we know that the cancer has won its fight versus the body immune systems. So what is been explicitly stated in this quite landmark paper here by Roberto Rangel and his co-workers is that in the past we knew that there is a disarray or a disconnect between the macro environment and in the macro environment, and we see that, as I told you in the previous slide, there is the war is won by the conversion of these cells into frankly malignant cells. But what this paper tells us today is that, some of these things could be at a cellular level also. Some of the changes or the predisposing factors could be at a cellular level, which means that some of the squamous cells themselves inherently may have the problem within, rather than the problem being in the broth thereby, in the nearby surrounding environment. So the genetic changes driving malignancy or immunosuppressive behavior could not only be in the macro environment, but also in the micro environment. What I mean is in the cellular level in oral pre-malignancy. So this is something that we have come to know now. So which means that which explains a lot of clinical situations where we come back as cancer surgeons. I'm sure Dr. Nanda Rajneesh and Dr. Rashmi will agree with me. We see a lot of patients who have no exposure to tobacco, no exposure to other environmental factors, but these people end up getting malignancy. In fact, right now, as I speak, I have a patient with me who has laryngeal malignancy, who underwent a laryngectomy in my center. And this lady from Cameroon has had no history of tobacco intake, no history of any, and she's a internal medicine professor from a very reputed university in Cameroon. And she has had no known external environmental triggers. So then in such situations, where does the trigger come from? So this paper says that they are, there could be microenvironment, which means an intracellular environment could dictate the progression of the disease. Now, this particular paper shows molecular genetic alterations during pre-malignant processes that directly correlates to carcinogenesis. So when epithelium moves from normal epithelium to CIS, that is carcinoma in situ, you have methylations. To detect methylation, you have these biomarkers which one needs to see. So similarly, in miRNA expression, you have the following miRNA expressions, and the biomarkers are on the right hand side. A little too technical, but for you to know that there are these elements that can be studied, and even in a pre-malignant progressive situation, one could detect, or we could have a situation where there is early detection of disease using these biomarkers. Now, the term pre-malignant condition itself was proposed or brought in by a Romanian physician by the name of Victor Babes in 1975. So he termed the pre-malignant conditions pre-preliminary and malignant cancerous lesions and conditions. The term leukoplakia was first coined by Schwimmer in 1877 and classified by WHO in 1994. But for me, in being a head and neck oncosurgeon, these are very important names because the Plummer-Vinson syndrome is quite a characteristic disease in the upper aerodigestive tract. The Plummer-Vinson syndrome is characterized by esophageal webs, especially seen in the upper part of the esophagus or in the postcricoid region, along with a couple of other conditions like stomatitis and colonychia. I'm going to come to that later. So this is a very characteristic condition and one of the strange conditions, which is a pre-malignant conditions detected by Plummer and Vinson, both of whose pictures are seen here. Now, oral submucous fibrosis was first detected by an Indian origin physician by the name of Mr. Joshi and Schwartz in East Indian women in 1952. So initially, the pre-malignant conditions were termed as pre-malignant disorders, but in 2005, the WHO workshop on this particular panel renamed pre-malignant disorders conditions as potentially malignant disorder. So we all need to be on the same page. I believe that standardization of nomenclature and literature is very important when it comes to reporting, because only when we report things properly do we end up with good scientific evidence. A group of disorders characterized by mutation-associated spontaneous hereditary alteration. So this is the definition which was worked up by the WHO workshop in 2005, which defined potentially malignant disorders. Now, again, pre-malignant or potentially malignant disorders should be classified as pre-malignant lesions because some of them are frank lesions and others are conditions. And if you go through the list, you'll understand why. So leukoplakia is a lesion, erythroplakia is a lesion. So leukokeratosis, nicotina palatinae is a frank lesion in the oral cavity and in the oropharynx, candidiasis and carcinoma in situ. Whereas pre-malignant conditions include oral submucous fibrosis, oral lichen planus, actinic keratosis, syphilis, and other conditions. Now, if you were to classify oral potentially malignant disorders, again, they're not pre-malignant disorders anymore. They're potentially malignant disorders, and OPMD is a certified entity, oral potentially malignant disorder. We call them OPND. So this is divided into habit-related and non-habit-related disorders. So habit-related disorders are most commonly tobacco-related disorders or lesions and betel net associated lesions. So under tobacco associated lesions, we have leukoplakia, we have stomatitis palatinae, nicotinae, tobacco pouch keratosis, whereas under the betel net associated, which is more of a South Asian phenomenon, we have oral submucous fibrosis, sanguinaria keratosis, associated keratosis. And in non-habit related OPMDs, we have actinic chelosis and chronic candidiasis. So in group 2, there are inflammation-mediated mutagenesis. So the previous ones were habit-related. Now there is inflammatory. So under inflammation being the causative factor of pre-malignant, potentially malignant disorders, you have internal derangements causing chronic inflammation, that is lichen planus and discoid lupus erythematosus. And we have external factor causing chronic inflammation like mucosal trauma, sharp tooth, lichenoid reaction, poor oral hygiene, chronic infections, which could be bacterial, fungal, viral, and prolonged untreated oral inflammations of the oral cavity. Now, this is a no-brainer. We all know, most people who are following this subject would know that the etiology of one of the most common etiology for oral malignancies, and India is considered one of the world's capital of oral or head and neck malignancies. The 6 S's, as they're called, is smoking, spirits, sharp tooth, spicy food, syphilis, and sepsis. So these are called the 6 S's as far as etiology is concerned. And then, of course, tobacco, arecanut, which is quite India-specific, I would say, alcohol, canidial infections, viral associated HPV infections, and vitamin A deficiency. Now, arachinet leads to a lot of, it's again, as I told you, India specific. Now, when arachinet, so we have, there have been extensive studies that talk about what arachinet does. And when you look at the studies, they clearly have identified loci which are where the genetic mutation occurs for each specific event. If you see here, ROS, hypoxia, EMT cancers, and what is this? Cancer STMS, so each of these, it's a slightly complicated slide for me to understand as well. So if you look at this, the loci of what I have understood is that each of these different events that occur during cancer neogenesis is linked to genetic loci which have been determined, and then thereon that is determined to cause inflammation, genetic cytotoxicity, autophagy, migration, invasion, and self-renewal and stress tolerance. So this is carcinogenic progression, if you see here. So if you look at areca, this slide is important because from an Indian scenario, we have arachinet being a very, very predominant cause. So you see that arachinet stimulates almost all of these pathways. It triggers all of these pathways, and we have been able to, as I told you, determine the genetic loci for each of these pathways. And it's important to note that multiple pathway stimulation means higher chance of carcinogenesis. Now coming to the clinical parts, which is something probably which would be more evident and easy to understand. We have leukoplakia. So this is a picture of one of my patients with leukoplakia, which is a whitish lesion of the oral mucosa. For the non medical personnel here listening to this for this lecture, if there is a patch like this on the exposed parts of the upper aerodigestive tract, this is a potentially malignant disorder. One needs to report this immediately, So it's quite often seen in the buccal mucosa, but here you have a lesion seen on the tongue. And then there is something called hairy leukoplakia. So this is kind of an intense leukoplakia. You see nice thick keratosis, nice thick whitish mucosal or epithelial change with some polypoidal tissue. So this, again, all these kind of presentations most definitely need to be reported to a cancer surgeon or somebody who deals with head and neck oncology. Lichen planus looks something like this. It could be an autoimmune disorder. It's very likely to be an autoimmune disorder. We still don't know much about lichen planus, but then you see thin whitish lines with erythematous lesions next to it, and it's generally seen in this area. It's also seen in the tongue, quite commonly seen in the tongue as well, but in the buccal mucosa, again, could be due to a sharp tooth or due to contact mucosal ulceration. Direct immunofluorescence can be used to confirm lichen planus. Now, stomatitis palatinae nicotinae is a classic condition. It looks something like this. You see whitish papular lesions in the hard palate. This one is on the hard palate. You see nicotine stained teeth here. You see, I see a lot of patients in my OPD where where the teeth are stained like this, especially in betel nut chewers, or smokers. I immediately tell them to visit a dentist to clean off these blackish areas, because it's very important to take out, these are nicotine spots. It's very important to eliminate them because over a long period of time, these things themselves can give rise to malignancy. They can act as those external triggers for malignancy. So stomatitis palatinae nicotinae looks like papular lesions on the mucosa. Erythroplakia, again, like leukoplakia, but reddish in color. You have reddish spots either on the tongue or in the oral mucosa, which don't go away. They could be quite painful spots, especially while eating spicy food, which is quite common in Indian condition. So if there's a reddish spot on the tongue or the oral cavity, which doesn't go away for a long period of time, then it should be potentially treated as erythroplakia. Now, oral lichen planus again is generally bilateral. It appears in midline areas. It's most commonly seen in the buccal mucosa, tongue, gingiva. It could occur anywhere, not so much in the lower parts of the upper aerodigestive tract, but yes, in the oral cavity, it's pretty common. So it is reticular, it's popular, atrophic erosive changes could be seen in oral lichen planus. Now there is this quite rare condition called actinic keratosis. I've not been able to take a picture of this myself, although I remember seeing one of these cases several years back. But, if there's a long-term sun exposure seen in whitish population, in a Caucasian population. So when there's a long-term sun exposure, this kind of whitish line or a patch on the vermilion border of the lip is quite characteristic of actinic keratosis. Then you have what is called discoid lupus erythematosus. So again, these are by definition circumscribed, slightly elevated, whitish patches that could be surrounded by a reddish hue. So quite characteristic, discoid lupus erythematosus. So again, direct immunofluorescence can prove to be quite handy in diagnostic. Now, this condition is a part of the condition that I just mentioned before, Plummer-Vinson syndrome. So sideropenic dysphagia is bottled tongue with some fissures. So this is quite commonly associated with an esophageal web and koilonychia. So it's a part of the Plummer-Vinson syndrome. So if there's a tongue like this, which is bald with fissures, one needs to also think of doing a upper diagnostic DL-scopy or a panendoscopy to rule out an esophageal web. So we all know that there are non-surgical methods or treatment options when it comes to pre-malignant lesions. So surgical options obviously are when some of these lesions don't go away. But pre-surgery, we look at non-surgical options first, and only when they fail, we go in for surgical options. So photodynamic therapy is quite beneficial in pre-malignant lesions. L-ascorbic acid in form of tablets, isotretinoin at the dose of 28,500 international units per day. Beta carotene is something that we all give for pre-malignant conditions. Now, bleomycin is available as topical applicant, which also can be used. It's a chemotherapy drug which can be used for pre-malignant lesions. And surgical excision obviously involves laser excision. I use laser for most of my superficial lesions. Cryotherapy, I don't use it so much, but yes, electrocautery is the old way of dealing with things. Scalpel excision and stripping again is something that we used to do in the past when I started my practice. But today I use a CO2 laser for most of my pre-malignant lesions because it's quite precise and bloodless. So how do we go about, what's the chart or the treatment protocol for pre-malignant conditions? So let's say that there is a oral lesion, and if there's a previous clinical history, we wait and watch. We wait and watch and see if the lesion first resolves with or without therapy. If the lesion resolves with therapy, fine. Without therapy, fine. If it resolves with therapy that I showed you in the previous slide, then we simply do a nice follow-up of this patient for a year or so, and then we relieve the patient. Now, if the lesion persists or if it progresses, we need to take a biopsy because we need to know if the pre-malignant lesion has actually turned into malignancy, because the treatment changes substantially if the pre-malignant lesion turns malignant. If it's a pre-malignant lesion, a local wide excision could suffice. But if it's a frank malignancy or even a carcinoma in situ, you are then looking at the nodes and more distal spread of the tumor, which would mean that if a surgery is performed, we could be looking at a lymph node excision, neck dissection and those kind of things. So if we perform a biopsy, identification of histological entity without presence of malignancy. If it's without malignancy, as I told you, you use the surgical options and then take out the lesion which is not responding to medical management. And if it's with malignancy, then the malignancy protocol sets in, which means that if it's a T1 lesion, we could do just a wide excision as in the case of pre-malignant lesion, or we could look at if there are neck nodes, which can happen rarely even with the T1 lesion, because oral cancers are quite prone to get good, nice neck nodes. So you could do a neck dissection as well, or at least irradiate the area to ensure that there is no metastasis. So now these are some of the lesions that we put up from some of our slides. This patient in particular is very well known to me. So this lesion here began as a small whitey patch, which was followed by his children and in-laws who are also doctors. So the classic protocol of wait and watch was adopted. This was after a few months, and then you saw that you see that there is a bigger whitish patch. There was progression. A biopsy was done. You'll see that local anesthesia was given. Biopsy was done. The lesion was taken out, and it turned out to be a carcinoma in situ. And then there was a slight delay in in opting for surgery. And when this patient was brought to me, there was an ulcer of this size, which is a frankly malignant condition. Now, with a practically 1.5 centimeter ulcer, I did not want to, since I knew this patient very well, I did not want to leave anything to luck. So I went in for local wide excision with neck dissection. So this is the left side of the tongue. As you see, there's a big wide ulcer. So this is to show you how a pre-malignant lesion can turn malignant, so that's why they're called pre-malignant condition or potentially malignant condition as per the WHO classification. So what did we do? We went ahead, did a wide excision. Whenever we do a wide excision, we keep a nice margin of approximately 1.5 to 2 centimeter. So that margin has been kept, and what I'm doing now is taking the deeper margin also needs to be of the same diameter, and then we take out the whole lesion with a nice margin, suture it nicely, and then I'm commencing the neck dissection. So I'm doing a neck dissection, thick fat neck, which means nice fat, subcutaneous fat, which is not the most ideal situation, because I would like to look at the lymph nodes nicely. You see this lymph node here, big lymph node. So some of these fat can kind of mask the lymph nodes. So I like thin skin, thin neck, but this one turns out to be nice and chubby, which means that, now every bit of tissue, which is not an important structure here, needs to be taken out. That's my principle. You see the sternocleidomastoid here, the submandibular gland is here, the tail of the parotid can be seen here, the strap muscles are here. So as I dissect, I have now been able to take out everything. You see, there's just muscle, the internal jugular vein, and this is the digastric muscle. The hypoglossal nerve can be seen here. The omohyoid muscle is here. So supraomohyoid neck dissection has been commenced, and I've been able to take out. Now, this is the submandibular gland itself being taken out, because there are a lot of lymph nodes around the gland, level 1A, 1B, and this is the entire gland having been taken out. You see the digastric muscle in all its glory. You see the omohyoid muscle and the entire supraomohyoid, above the omohyoid, supraomohyoid neck dissection. Carotid is here, IJV is here, the hypoglossal nerve is here, and the mylohyoid muscle is seen here. So this submandibular gland goes around this muscle on either side, and we take out the whole gland, and that's the final picture after resection. So this is now so I had one more slide where I was I had probably shown the hypoglossal nerve and the lingual nerve, probably not here, or maybe this has to be turned around. But you could see the lingual nerve and the hypoglossal nerve. So for those of you who are familiar with neck dissection, that's the limit of a supraomohyoid neck dissection. Now, oral submucosal fibrosis is characterized by collagen deposits in the mucosa. So this is a very strange, very characteristic entity, which is very specific to pan chewing, okay, or beetle nut chewing. So in the first stage, we have stomatitis and mucosal ulcer. Now, this is very easy to confuse oneself with general stomatitis, general ulcerations, and without really being able to pin it down on oral submucous fibers. But later on, just gets about a little characteristic, which means that due to the collagen deposits in the submucosal area, the patient develops trismus, pale nasal mucosa, stiffening of the mucosa, and fibrous bands over the mucosa. The third stage is obviously the sequelae or complications of which could be ulceration and development of frank malignancies. So Candidiasis is another condition which is common, especially in immunocompromised individuals. Oral thrush, as we call it, can be in the oral cavity, oropharynx. It could be in the esophagus. It could be in the larynx as well. So Candida albicans is the most common strain. Chronic hypertrophic variant is of the highest association, and as I told you, it is quite commonly seen in immunocompromised individuals, like in HIV infected. We used to see a lot of this during our growing years, learning head and neck oncology. So diabetes mellitus, xerostomia due to, let's say, parotitis, parotid resections, and other things. So all this can lead to candidiasis. Now, since I deal with the larynx, and we do head and neck cancers of all kinds, we some slides on respiratory papillomatosis. So lower down in the larynx, we could have what is called respiratory papillomatosis, which is quite characteristic. So there is this proliferative growth which is seen in various parts of the larynx. It could be seen in children as well. And when you see something as proliferative as this, with let's say mobile cords or whatsoever, or if there are some of these lesions in the oral cavity as well, because they can be multiple. A lot of times it could be multiple. So we are talking about recurrent respiratory papillomatosis. Now this is closely related to infection with HPV 6 and 11. So as I told you, it can be, I've operated on a small child, as young as, I think, if I go far back in my practice, I remember this young child, hardly 4 or 5 years, with the stridor, with this huge mass. I use laser to excise. You really can't be quite aggressive too with some of these cases, because they're not frank malignant conditions. So, and in children, it could be quite catastrophic to be taking out, doing radical resections of the larynx. So laryngeal leukoplasm, I'm going a little faster because I've got a lot of things to show, but I don't think this is going to be a whole evening affair, so we have limited time. So I'm going to quickly go through some of these conditions. Laryngeal leukoplakia, again leukoplakia as seen in the oral cavity, but also in the larynx. Now, this is one more condition, a total laryngectomy being performed. I'm showing this because the message here should be to nip the disease in the bud. I don't want to be performing heroic or, these so-called, big surgeries for cancers of any part of the head and neck, because one needs to identify, and I think the whole motive or the goal of SPOC is to increase cancer awareness so that we don't reach a stage like this where we show laryngectomies like this. You see, this is the head end of the patient. This is the chin of the patient. This is the neck of the lower neck. This is a patient who had a pre-malignant condition. If I remember right, it was leukoplakia, which turned malignant on follow-up elsewhere, and the patient was brought to me. The strap muscles are here. You see, I've opened up the strap muscle side view here. This is the submandibular gland. I'm doing a neck dissection here. You see all the nerves, cervical lymph node, superficial deep cervical nodes, nerves are preserved. Lymph nodes are taken out. Now you see the carotid in all its glory, the IJV in all its glory, all the lymph nodes taken out, digastric muscle here, strap muscles here. I open up everything. And I start releasing the larynx. The larynx is pedicle, supralaryngeal pedicle, superior thyroid pedicle, inferior thyroid pedicle. And this is the opposite side. I do the same thing. The thyroid is preserved on the opposite side because it was normal. But we've nevertheless done a resection of all the lymph nodes on both the sides. This is a top end view. This is entering the larynx. We open the larynx. And then now again, side view here, the larynx, which is nothing but the voice box, is taken out. Completely, again, top view, going into the larynx. I'm seeing the larynx. Now, this is the cancer. You see this? This whole thing is cancer. Okay, so there was a huge lesion here on one side of the larynx. We are opening up the larynx like a book, and this is an upside view. Okay, so I've taken this picture from the top. This is the chin. This is the sternum here, and the whole laryngectomy has been performed. Half the thyroid is preserved, and now we stitch up the postcricoid area or the esophagus, and that completes the laryngectomy. Okay, so this is the final picture, and that's the specimen with. So again, skull base. Now my area of expertise is the skull base. So I was in Europe, as I told you, learning skull base surgeries. What can predispose to a skull base malignancy? any infection of the ear. Now this lady came with chronic ear infection. Chronic ear infection, can it be a premalignant condition? Of course, yes. Squamous cell carcinomas of the temporal bone are come out of the milieu of a chronic ear infections. Very rare to see leukoplakia, or if there is one so-called pre-malignant condition that I would pick out in a skull-base malignancy, it is chronic ear discharge or chronic ear disease. Now you look at this. This patient had ear infection for more than a year, and then when this patient was brought to me, there was this huge lesion. Now I'm removing this cancer here. I've done a mastectomy. This is the ear, right side, sigmoid sinus, middle fossa dura. This is the ear canal per se, the ear as we know it. But I've taken out, retracted the skin forward, parotid is forward. So I'm taking out this whole thing, en bloc resection. This is me closing the ear canal from the other end. I'm closing the ear for good. I'm closing the ear for good. You see the ear is closed for good. Now I do a parotidectomy. I do a en bloc resection of the external ear canal, go all around it, removing the ear canal like this. Now you see how I've nicely done an en bloc resection of the ear canal, but the lesion is seen to be going. Now this is the facial nerve going into the parotid. I do a clearance just behind the facial area in the occipital area. Now the facial nerve is here. Ear has been cleaned out, but the parotid is not. Parotid is still infected, not really infected, but infected by the tumor. The facial nerve going to the parotid. Now I'm doing a resection of the stylomastoid foramen. This is frank skull base. The styloid process is here. Facial nerve going into the parotid. I am now dissecting the lower branches of the parotid, upper branches of the parotid, and I am taking out the entire frontal branch of the facial nerve going into the in the frontalis muscle is all taken out. Complete parotid resection, leaving behind a small parotid tissue lower down. So we've come to being a little more conservative, even with malignancy. You see, during the beginning of my practice, I would do a total parotidectomy, resecting all the entire facial nerve. But today, you see, I take all the pain too, because our radiotherapy is better. So I subject this patient for radiotherapy. At the end of it, you see, facial nerve preserved right up to the frontal branch, all the branches preserved. Small part of the parotid lower end also preserved. And the rest of the parotid, along with the temporalis muscle, resected. The lateral pterygoid, medial pterygoid muscles are also resected. Now we see the condyle of the mandible. I have also preserved the condyle. Earlier I would resect. This would be called total temporal bone resection, but now we have got more and more and more conservative. This patient I did a BAHA, that's bone anchored hearing implant for restoration of hearing, because we are closing the ear, right? So the whole ear is closed along with the tumor resection. So how do this patient here? We put an implant simultaneous. So these are some of the cutting edge things. So we have resected the tumor. This patient is surviving for the past 2 years. Earlier, and 2 years is a disease-free survival for 2 years on constant follow-up. And I'm glad that we chose to be conservative in our approach. So now I would quit some of these slides because I would like to show you something about something for the public would probably, because I know a significant population of our audience would be people wanting more elementary knowledge. So I would like to touch upon naturopathy. So what cancer and naturopathy? A lot of people keep asking me, can I go? We have a great naturopathy center here called the Jindal Institute of Naturopathy, and many people, including some of my family members, have been there. I wish to go there someday. There's so many nice things being said about this center. So is it relevant? What principle does it work on? So the effective way of battling cancer, as per Dr. Jindal's own, I'm quoting him verbatim, is to starve the cancer cells by not feeding it with the food it likes and needs to multiply and build strong immune systems with appropriate food and beverage through nutrition. So what is proposed? Now, do we have a scientific basis to it? Some of it is backed by science, some of it is not. And, being a doctor coming in from the allopathic background, I will not vouch for the scientific nature of this discussion from here on, but I truly believe that nature is the biggest doctor here. I truly have, if one thing I have learned from my clinical practice, that is to be optimistic, and I have been humbled by several situations where nature has defied all scientific logic. I remember the case of a huge oropharyngeal malignancy, huge neck nodes, ulcerative skin involvement, which was, this patient, was blind, war veteran, Indian patient here, came to me, refused surgery elsewhere. I mean, not really refused, but people told that, this requires palliative care, not curative therapy by the top cancer centers. And I, being a very optimistic head and neck oncosurgeon, because my dad has taught me to be optimistic. He was a head and neck founder member of the Head and Neck Oncology Society of India. So he had some spectacular stories. So I said, I'll take it out. I'll take out this tumor. But I won't assure, but don't expect the moon. My job is to take it out. I'll do the cancer surgery that it needs. I'll take out everything, the entire disease, follow it up with radiation, and then hope for the best. So when the so-called incurable cancer was present as like stage 4, not stage 4, like stage 10. If it could be stage 10, because stage 10, but there are only 4 stages in cancer. So this was like a massive malignancy. I took it out. I did a commando surgery. I took out the lesion, did a neck dissection, pectoralis flap, sent the patient for radiation. It's now 3.5 years since this patient has undergone surgery. Perfectly fine, absolutely okay. And he's disease-free. So now that defies all scientific logic. So similarly, not everything is science. There's a lot that we don't know. Nature is still the best doctor. For every cancer that manifests, I'm sure the body and our food and the way we keep ourselves, our immune system is killing 9 out of 10 cancers. It's that one cancer that comes out which we treat, but the body is treating 9 out of 10 cancer cells that keep showing up in our body, and there is a way to do it. So the key principle of cancer prevention diet is rainbow assortment of, so this picture, rainbow assortment of fruits and vegetables, reduce pesticides, herbicide exposure, avoid animal food, meat is what is proposed, omega-3 fat flax seeds, avoid high calorie, low nutrient junky diet, obviously, low salt, high potassium diet, and stop chewing pan tobacco in any form, and also reduce sugar intake. Now, there are some things called superfoods. Superfoods are foods which are frank cancer fighters, So garlic and turmeric is supposed to be one such food. Carotenoids and bioflavonoids stimulate immune system. Carotenoids have direct tumor toxicity. So you have to avoid things that have carotenoids. Wheatgrass is supposed to be a superfood. Lemon peel, and this picture here is that of a guanabana, sour soup fruit, which is supposed to be the superfood when it comes to head and neck cancer or cancer of any part of the body. And of course, our own tulsi or turmeric, which is richly provided in our Indian cuisine. So dark colored vegetables like carrot, spinach, tomatoes, yams, sweet potatoes, and targamu, and fruits like cantaloupe, apricot, citrus fruits, soya, and other legumes are all supposed to be cancer fighters. Vitamins, we all know, post-COVID, I've seen a lot of may not be directly related to cancer, but I've seen a flare-up of tuberculosis. I've seen a flare-up of viral infections, post-COVID. And that's because of vitamin D deficiency, because we stayed indoors, there was a lockdown, and when there is vitamin D deficiency, calcium deficiency, that has led to similarly deficiency in vitamin A, vitamin C, vitamin E, and glutamine. All this is proven to be good for cancer. So what does cancer feed on? What do cancer cells, the mutant cells feed on? Sugar, they say, has to be cut down. Milk produces mucus, which is cancer feed, substituted by unsweetened soy milk. Again, don't hold me, not all of this is cast in stone. So despite the fact that I'm propagating these things, some of these things, as I told you, could be scientific, some of them not, but there's no harm in, let's say, sticking onto a diet once in a way and seeing how it goes. Meat apparently raises acidic pH to be cut down. And this is from Dr. Jindal's naturopathy, protocols. Obtain live enzymes via fresh vegetables, juices. He's a big proponent of vegetable juices, sprouts and fruits. Water, he says a lot of water, constantly drinking water apparently feeds cancer cells. But I told you, this is not subject to scientific debate. Caffeine, chocolate, tobaccos, obviously. Deep breathing and exercise for oxygenation, I'm sure would help, because that would increase oxygen levels of the body. Again, there are many things proposed here. So I would like to, eventually conclude by, stating that James Allison and Tasuku Honjo, they shared the Nobel Prize in 2018 for the discovery of cancer therapy by inhibition of negative immune regulation. Now, this entire thing was stated in my first few slides. We went through all that. So, as a medical community, this slide is to show that we are constantly, our community, I may be a cancer surgeon, we do our bit. There are, immunologists there. There are scientists there constantly fighting cancer, constantly providing path-breaking research, innovations and technology to fight cancer. So be rest assured, as a medical community and as a part or representative of the SPOC, we are doing our bit. We are doing everything that's needed for cancer prevention, cancer cure, and cancer research. Thank you one and all for a patient hearing. And I hope I've done justice to this topic that has been proposed to me by Madam. And I wish you all a great evening. Thank you once again.
Thank you, sir, for this very informative and wide session, which actually helped both the doctors and others as well. Audience would love to hear from you if you all have any queries or questions. We actually have a question, sir.
Yeah.
The question is, do you need to do HPV screening in every pre-malignant stage? And if so, please give details.
No, HPV screening is not necessary in every pre-malignant stage, Like, for instance, in see, there are certain conditions which are directly related to HPV, nasopharyngeal carcinoma, papillomatosis. In these cases, definitely I would do a HPV screening. But if there's if I know that there is a smoker who's got a or a puncturer with, let's say, leukoplakia or erythroplakia, or something that's directly fitting into the clinical scheme of things, I would not jump into doing a HPV screening for every single case. But yes, it will be top on my list for in case I don't find a correlative clinical history, like if there's no sharp tooth. Now, if there's a sharp tooth and next to that there is a contact ulcer, and that turns out to be a pre-malignant condition, then I would probably not do a HPV screening. But if I don't find a cause, if 1 + 1 is not 2, if things are not perfectly clinically explainable, then I would do a HPV screening, most definitely.
Participants, any more questions or queries? Well, we also will have a recorded version of the same webinar, which will be available. So later, if you all have any queries, please do get back to us. Thank you, sir, for this informative session. Thank you, ma'am, for this great opportunity for us, and which was greeted and treated well by all. Thank you all for your patient hearing, for taking time off your personal works and other things. And wish you all a very good evening, and thank you.
Thank you, Nanda madam. Thank you, Dr. Rashmi.
Thank you, sir. Thank you.